part of a growing group of people that we call ourselves OR, Organizing Against Racism. And we are from many faith backgrounds, from many races, from many towns, and in the Triangle area. So raise your hands if you're part of OR. A handful of people. Okay, great. This is the third part of a four-part series looking at race and racial equity issues. We looked at different politics. Now we're looking at healthcare and health reform. We also are going to be looking at education. So there's a flyer in the back on October 18th, which is a few weeks from now. We're going to be talking about education. It's actually going to be in this same building. And we've got some great people lined up for that panel conversation also. So please grab these and help distribute them if you can. And again, we thank you all for being here. So the focus of tonight's conversation is healthcare and healthcare reform, and looking through a racial lens at healthcare and healthcare reform. And we've got four people that I think are top-notch to do the talking. First, I'm just going to do a quick introduction to each one of them. Then we'll have Gayle Harris come speak, and Pam Silberman. They have PowerPoint presentations. And then we'll have a panel. They're going to be answering several questions, and then we'll take, questions from the audience as we go forward. So let me start with Gayle Harris's introduction. I was just, she's a friend of mine. She is the director. We were thrilled when she was named the director. She's the director of the Durham County Health Department, and she is engaged in everything in Durham related to health. We are thrilled to have her. She helped start the Project Access to help uninsured people. She's doing all sorts of dental things for dental care in Durham. She's already done the normal health department things. Have a very active Healthy Care Lineage group in Durham County. She has her bachelor's degree from Duke in nursing, but then she saw the light and went to UNC School of Public Health to get a master's degree in public health nursing. So we're thrilled about that. And if you want to know anything about her grandchildren, she's got pictures and she'll tell you all about it. Can't get away from it. So we're thrilled to have Gayle tonight. Also we have Pam Silberman, who is the president and CEO of the North Carolina Institute of Medicine. She has her PhD, I guess, in public health. Is it public health? Right. But the thing that I would say about Pam that's so impressive, while she knows all the details of the federal laws, federal legislation, state, she is one person that you can go to for incredible detail, but also big picture about healthcare in North Carolina, quite frankly, in the country. She is renowned for her incredible depth of knowledge, so we are thrilled to have her. But she's never too proud to get involved in community health because she understands healthcare is local. So we are thrilled. She's done lots of good things in Durham. Also helped Project Access, which is care for the uninsured people getting specialty care. So thank you, Pam, for coming. Next we have Cedric Bright, who is with School of Medicine at UNC. He also saw the light. He was at Duke for a while. I'm sorry. I've been in Durham and I'm a Duke, I'm a Carolina girl. I said who I am. My name's Gina Upchurch, and I'm with senior pharmacist in Durham, but part of this organizing group tonight. Dr. Bright was the 112th president, he still is, the 112th president of the National Medical Association. He ended his term last year, but he'll tell us some about what he was working on when he was with them tonight. So we're thrilled to have him. He traveled all around the world, all around the country, talking about healthcare and healthcare reform. So we have him right here in Chapel Hill. We're thrilled. And lastly, Adam Searing. Well, who doesn't know Adam Searing? Okay. If you read any of the newspapers, and he won some huge award. Was it the Kaiser Family Foundation? Who gave you that award last year? You can't remember because there's so many. The advocacy award you got. Kaiser? Families USA. Families USA just gave him the world's best health advocate award for the country. Wow. That's what it was called, something like that. He is an attorney, and then he also has his master's degree in public health. But what I remember about Adam most is we were in public health class together, and the professor was going on, and nobody really understood what they were saying. And Adam goes, "Excuse me," and he stood up and he articulated, and we're all like, "Oh, we get it now." So Adam's job, quite frankly, in healthcare is helping many of us understand the issues at hand with regard to healthcare. So we're thrilled to have Adam. And Adam speaks his mind, which is excellent, excellent. So we're going to start off with Gayle. We're framing tonight by talking a little bit about health disparities. And these speakers have had to be very brief, unfortunately. So Gayle and then Pam will give us an overview of the Affordable Care Act in 15 minutes, can you imagine? And then we're going to have a panel to get into some of the issues around race and racial equity. So Gayle, you.
I want to talk to you a little bit about Durham. We're a really interesting community in that we are a minority-majority community in that we have a growing people of color population with our Hispanics, when we look at them across any race, being 13.5%, our white non-Hispanic 42.5%, African American 38.5%, and then we have a mixture of people from other races, and some people choose to select several different races. So that doesn't really add up to 100%, but it's somewhere thereabouts. In our community, if you take the behavior risk factor surveillance data about who's uninsured between 18 and 64, we've come down to 17.7. There are some different data out there, but we've been looking at this over time. Now, we also have huge resources in our community. This is a slide about that, but we do have huge resources. Lots of people who take Medicaid, our Lincoln Community Health Center sees the uninsured. We were just talking about their business model, where 80% of their customers are uninsured, and 78% under 100% of federal poverty guidelines, something thereabouts.
More like 87.
And more like 87%.
Wow.
So they keep their doors open on magic. But healthcare is the second most expensive cost for the people in many of the families in Durham. Lots of issues around food insecurity. We are sort of a tale of two cities in that we have a median household income of $49,800, a per capita income of $27,000, and then we have 25% of our kids living in poverty. Much of the monies that are made in Durham County don't spend the night in Durham County. So oftentimes our population that suffers or that is underserved or with great needs, they get kind of covered up in the wealth that's also there. Infant mortality is oftentimes used as a window to reflect the health status of a community. And if you look at our overall rate, which is about 6.8, you say it's not bad. That's below the 7. We had this benchmark for helping people 2010 that said we want everybody the infant mortality rate to reach 7 for everybody. But if you look at what it is for white, non-Hispanic, and then look at African Americans, it's almost 12 in the city of Madison with many, many resources. And then if you look at the age-adjusted rates for heart disease, overall it's a little over 150 per 100,000. For African American males, it gets up to 250, a little bit over per 100,000. African American females, slightly under 150,000. So if you put those, there are huge disparities when you start looking at those. Same for, well, not as bad, but for strokes, with African American males leading the pack. And so you'll see a trend. Those that are least likely to go for healthcare visits on a regular basis are African American men. So the next one. Cancer, same difference. African American men right up there, towering over the overall rate. And then type 2 diabetes. African Americans faring much, much worse in mortality around diabetes. And in just the morbidity that's associated with diabetes, African Americans are 128% more likely to develop complications from diabetes. And then if you look at AIDS, deaths from AIDS, now there were, in this time period, this 5-year interval, there were 76 deaths 10 of them were to individuals who were not African American. 5 white men, 2 white women, and 3 Hispanic men. And the African American death rate is almost 20 per 100,000. And we rank in the state of North Carolina 4th in the state for HIV morbidity. And African Americans are 9 times higher than whites. If you look at homicides, African Americans are most likely to be impacted by homicides, and that too is a public health issue. There were deaths for homicides for whites, but they were statistically insignificant. They couldn't come up with a number for it. And so between African American males, I think, and the homicide rate, I think we had 80 deaths just from homicides. So we have health disparities in our community. We're struggling to close those gaps, but many times it's the social determinants that impact those that prevent us from being able to make the difference that we need to make. And there are many things in the Affordable Care Act that will lend itself to closing some of those gaps and making health care accessible for many people who don't.
Good evening, everyone.
Good evening.
So this is going to be a real challenge for me. So if I talk really fast, you'll know why. Okay, so what I'm talking about today is the Patient Protection and Affordable Care Act. It's actually 2 pieces of legislation that was passed in March of 2010, and I'm going to refer to it as the ACA. I'm going to give you a quick overview, and then I'm going to highlight a couple of data pieces on the Affordable Care Act. What the Affordable Care Act does, and all of you have heard about it, is most of what you've heard is that it expands coverage to more people in our country. It is not universal coverage. It gets us closer to universal coverage, but it does not provide health insurance coverage to everyone. And what it does is it builds on our current system of health insurance coverage. If you look around the room today, most of us are getting health insurance coverage either through our job or through our spouse's jobs or our parents' job. Some of us also get access to health care coverage through the government, either Medicare, Medicaid, or our CHIP program, which is NC Health Choice. And about 6 or 7% of our population go out and buy it on their own. And that's in fact the way that the Affordable Care Act builds on health insurance coverage. It builds on those 3 ways: employer-based, government-based, and people buying it on their own. What you don't know, before Gina goes on, and I like to joke about this, is that I was a geek enough to go and count the pages. But anyone got a guess how much of the bill actually, in terms of pages, actually addresses the coverage provisions?
20%.
25%.
That was good.
25% of the bill deals with coverage. The rest of it deals with all the other things you really need to address if you're going to ensure a really working healthcare system. It deals with prevention. It deals with healthcare providers. It deals with access to care. It deals with quality of care. It deals with changing the way we pay for and deliver health care so that we can help reduce healthcare costs and improve quality. So there's a lot more in the bill that we never hear about in the press because we focused in on the coverage provision. Okay, so let's talk about who's uninsured in North Carolina. Actually, a little bit more recent data came out that says about 1.5 million non-elderly in our state are uninsured. It's about 19% of our non-elderly population. We focus in on the non-elderly because we do have universal coverage in this country. It starts at age 65. If you take a look at the income of the uninsured, about 43% of the uninsured in our state have incomes below 138% of the federal poverty guidelines, and we'll talk about that in a minute. Okay, if you also go on to the next slide, you can see in terms of who are the uninsured. If you look at the left, the pie chart, about half of the uninsured are white. And then you can see about 26% are black, 20% are Hispanic. But if you look at the right side, that's your risk of being uninsured if you are in that ethnic or demographic group. So if you're white, your chance of being uninsured is 15%. If you're black, your chance of being uninsured is 22%. And if you're Hispanic, it's almost 50%. And that's because a number in North Carolina of the Hispanic population are undocumented, which makes it much more difficult for them to get health insurance coverage. So the ACA, as originally enacted, not before the Supreme Court, the ACA as originally enacted would have reduced the numbers of uninsured in our country by about half. By 2016, the numbers of uninsured they were predicted to be at 56 million people by 2016. According to the Congressional Budget Office, it would have brought it down to 26 million people who would remain uninsured. And the way that the bill originally was going to do that is about half of the people would have gained coverage through Medicaid expansion, because the bill required states to expand Medicaid to anybody, almost anybody whose income was below 138% of the federal poverty guideline. Remember that first chart that I showed you, 43%? Those people would be getting coverage through Medicaid. The second is that it requires employers with 50 or more employees to offer health insurance coverage to their employees. And then finally, it requires individuals to go out and buy health insurance coverage if they, most people would have to go out and buy health insurance coverage, and there would be subsidies available to help people afford it. So where people would go buy health insurance coverage is through this new health benefits exchange. 2014, North Carolina, like every other state, will have something called the health benefits exchange. The easiest way to explain it, it is not a building in Raleigh. The easiest way to explain it is Expedia.com for health insurance coverage. Or Amazon, that's the example somebody else in my office uses. You get online, you figure out what's available, and you can sign up right there online. And that's the way we're going to be able to start buying health insurance coverage. And what's really neat about it is it will provide information about all the insurance plans that exist, what the coverage is, whether your provider's in the network, how much you have to pay out of pocket, what the premium is, and what the quality is, and then you can sign up online. So that's the way the bill was created. Of course, in June, if you all have been reading the newspapers, you know that the Supreme Court came out with an opinion that was totally contradictory to what everybody expected the Supreme Court to say. The Supreme Court upheld the individual mandate. All the legal pundits thought that they were going to throw that one out, but they upheld the individual mandate. But they held that the mandatory Medicaid expansion was unconstitutionally coercive to the states, and so the law could not require states to expand Medicaid coverage. They can allow states to choose to expand Medicaid coverage, but they can't require states to expand Medicaid coverage, and the rest of the bill is left intact. So what does that mean to North Carolina? Well, when we looked at it in North Carolina, our initial data suggested that in 2014, we would expand coverage to about 700,000 people in our state who are currently uninsured. About 300,000 of those people would get subsidies and go into that health benefits exchange that I talked about, the Expedia.com type of exchange, the private coverage that was going to be available. And about 400,000 of them would get coverage through Medicaid. But because of this new interpretation of the law by the Supreme Court, that Medicaid expansion is optional to the states, and we have to wait to see whether our legislature is going to choose to expand Medicaid or not. Most people are going to continue to receive the same coverage they have, so if you have health insurance coverage today, you're probably going to have similar health insurance coverage in 2014, except for you might get some expanded benefits. One of the things the legislation does is expand health insurance coverage for preventive services. So beginning, actually in your plans right now, depending on what plan you have, you may have full coverage for clinical preventive services with no cost sharing. It means women can get mammograms and pap smears. We can get bone density screenings, and there's going to be different kinds of coverage for both women, men, and children under the bill. There's also going to be mental health and substance abuse parity. Right now that exists for large employer plans. This will exist for all plans. There's other insurance protections that you all have heard about beginning in 2014. Insurance companies cannot deny coverage, they can't discriminate against you, and they can't charge you more based on your pre-existing health status. They also can't charge women more than they charge men. And there's only a limit on how much more they can charge the 64-year-old than they charge the 18-year-old. So that's the coverage. That's the very quick version of the coverage. And as you can tell, it's a very quick and very cursory version. But I do want to touch a little bit on the other parts of the bill because you don't hear about that much in the press. So there are provisions in the bill to expand access, to reduce health disparities, to improve quality, and also to reduce health care costs. So if you take a look at the provisions to expand access, Some of the things the bill does is to expand funding for community and migrant health centers. In Durham, that would be Lincoln Community Health Center. Here in Chapel Hill, that's Piedmont Health Services. So there's more funding to expand the number of community health centers around the state. There's some funding available to expand and to help support the building and the capital costs of school-based health centers. And there's some new funding for loan forgiveness to try to get providers into underserved areas. The problem in Chapel Hill is you don't have a huge problem with providers in Chapel Hill. Bertie County, or you've got a much bigger problem. So some of the rural areas, it's really hard to get providers in there. Second is there's some funds available to increase health professional workforce, and that's important because we expect in 2014 there will be a lot more people asking for health care than there has been in the past. When people gain coverage, they go out and try to get the doctors to see them. There's also some provisions in there to help reduce healthcare disparities aside from coverage, which will also go a long way to reducing disparities. There's provisions in there that's going to require any survey done by the federal government or paid for by the federal government to collect data on race and ethnicity and language spoken and disability status, so we'll have a much better idea of the health status of different groups. There's also efforts to reduce health disparities and to create more infrastructure at the federal level to really analyze and look at health disparities. The bill has a lot in there to try to improve quality of care. Gina and I were, in fact, just talking about that today. If you want to go online today and find out about hospitals, you can go on www.healthcare.gov. You can look at different hospitals, look at quality of care for hospitals and nursing homes.
Hospital Compare is where it is.
Right, it's also at healthcare.gov. You can look at hospitals and nursing homes from that website. So the ACA has provisions that are going to define what we mean by quality of care. They're going to require providers to report on quality measures. They're going to eventually make that data available to the public. Some of that data already exists. Some more data will become available. There's also going to be money to look at what works for certain people under what conditions. Okay. And then finally, there are provisions in there to test new models of payment and delivering of healthcare services with the goal of, it's called the triple aim. There's a goal of trying to improve the individual's experience with the healthcare system. That means improving quality and access. Improving population health, so that it's not just looking at the one-to-one doctor-patient, but it's looking at community health, and also reducing unnecessary healthcare costs. And so there are provisions in there to test new models with other provisions that say once we know what works, we can then expand that further across the country. So that is a very, 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 very brief overview of the bill, and I'm glad when we get to the panel to discuss any details you might have. So we're going to start with a couple of questions that came from the subcommittee. And raise your hand if you worked on the healthcare subcommittee. There are a bunch of us here, so thanks for being here. And so we're going to have a couple specific questions we'd like for them to answer, and then we're going to open it up for questions from the group. So the first one, can you see it? Okay. The first one, and if this is, no, she's not going to come off. So we're going to talk about wearing your racial equity lens. Think about at the federal level, federal decisions that need to be made, federal implementation that needs to happen with regard to ACA. Some of it's in place, some of it's not in place yet. With your racial equity lens, can you talk a little bit about what issues we need to be paying attention to in ACA and why?
So I was pleased when the HHS came out with new guidelines that work to disaggregate the data. Understanding that the health, when we look at, let's say, take for instance, our Latino and Hispanic population, if we look at, Hispanics, mostly meaning those that came from either Spain or from Puerto Rico, as opposed to Latinos, those that come from Latin America or from Central America, their health outcomes are different. And if you lump them all together as one group, you will never understand the true essence of what's going on within those subgroups. Hopefully we will get the same type of economization for African Americans, because there's African Americans and there's Caribbean Americans and then there's national Africans who are in America, then there are Jamaicans, so, and Haitians. So all of those in unique subgroups are different. Maybe not so much genotypically, but in some of the aspects that socially may determine how well they respond to things. So that's the first thing, and you got to have the data. The second part is you have to have the access, and I think that's where the individual mandate being upheld was great, but to then push it on down to the states, I think is going to be the true challenge. Just look at North Carolina for an example. We had a, what, $2.3 billion deficit that we looked at a couple of years ago, and where did we make our cuts? Healthcare, education. Those were the two major areas that we made cuts. So if we're going to be expanding Medicaid, or if we decide, depending on who wins, to expand Medicaid, we're going to have that same issue as where that money is going to come from. Fortunately, there are provisions within the ACA that lead to funding for the first couple of years of your Medicaid expansion that will, but after that, we're going to have to find that money within our own coffers. And I'll stop there for right now, let Adam speak.
Well, I don't, between all the speeches that came before, I don't know how much I have to add, but I would echo the Medicaid expansion. I think that's anything that the federal government can do to make it more likely that states expand Medicaid as they were planning to do under the Affordable Care Act is I think the most critical thing that we need to do.
The only other thing I'll add to this is one of the, I think, the disappointments about the Affordable Care Act is that there is a real concern that in 2014 we won't have enough providers to address the pent-up demand for health services that will come as people gain coverage. And if you actually look at the legislation, there's a lot in the legislation about health provider education, training models of care, bringing in more people of color into the health professions. But if you take a look at what was appropriated in the bill, there wasn't a whole lot of money appropriated for health professional education. So I think that that's an area. I know that the administration has been trying to put some funds into expanding health professional education and also targeting it to certain priority populations and priority professions. But I do think that's going to be a challenge that we're going to have in 2014, probably through about 2016. What we saw in Massachusetts when they expanded access is that for about a couple of years, access got worse in Massachusetts because there was pent-up demand. People who gained insurance coverage for the first time went into the doctor, meant more demand for the doctors that existed. And it took about a couple of years before that demand sort of curve went down and went back to a normal level, and now their access is much better. But I do think we will all, whether insured or not insured in 2014, experience some, we could potentially experience access barriers because we don't have enough providers.
And if I could just add on to that, that's why two things occurred. One, in the 2012 budget, one of the things that was zeroed out was money for programs called Health Career Opportunities Programs, which was the major federal funding that was put in place to ensure diversity in a pipeline. What they looked at and said, with the looming 2014 rush, so to speak, of folks coming into the market, they said that there's no way that we make instant doctors. They don't take a cup, put some water, and take something for it, and then poof, instant doctor. Doctors take at least 7 years, and that's 7 years after they finished college. Okay, so what they looked at is how can we try to change our resources? Understand that we're going to go to a team-based model, that we can maybe increase the members of the team such that a physician over a team can take care of larger groups of patients because we are working in a team framework as opposed to an individual. And I think that's really how the administration looked at this, as opposed to saying, we're trying to increase doctors. No, we're trying to increase the workforce.
I'm going to ask you all, and if you could talk a little bit. We've got Phil Harewood, who is the CEO of Lincoln Community Health Center. I think I And I see Howard Eisington, who's the Chief Medical Officer. He's in the back, right? At Lincoln Community Health Center here. And I'm not sure if there are people from Piedmont here too, but could you talk a little bit, I saw in one of Pam's slides, increase the number of FQHCs. That doesn't necessarily mean support the FQHCs that are already there. Can you talk a little bit about what that means and how the funding may?
Yeah, this
Why it matters.
is a challenge. So how many of you know what a community health center is? Good. So, okay, community health centers receive some federal funding. They're not completely federally funded. And they have a legal obligation to provide care to basically everybody, regardless of ability to pay. And they provide services on a sliding scale basis. They provide comprehensive primary care services. They also provide enabling services like interpreters or case management or transportation, because they serve, I think over 90% of the patients they serve have incomes below 200% of the federal poverty guidelines on a national level. So they're really serving vulnerable populations. Historically, community health centers, which are also referred to as FQHC, federally qualified health centers, historically, community health centers have had bipartisan support. It is one of the areas where they have been supported and expanded in both Democrat and Republican administrations. In the Affordable Care Act, there was $9.5 billion put in over a 5-year time period that was meant to expand the number of community health centers across the nation and also to strengthen the existing community health centers so that they could serve more of the patients come 2014. Because in fact in Massachusetts what they found is that the number of patients who went to community health centers actually increased. When people gained coverage, they didn't all desert community health centers. They continued to go there and they increased the number of patients they saw. And they also continued to be the primary source of care for the uninsured. So there was money put in. It was for 5 years to expand the number of community health centers. But last year during the budget negotiations, they cut the base funding for community health centers by $600 million a year. So for the next 3 or 4 years, there's still more money put into community health centers than there was before the Affordable Care Act, because there's still this increased money of the $9.5 billion. But there's a cliff in about, is it 2014, 15? 2015, all the new money goes away. There will be more community health centers vying for the little bit of money that still exists, and there will be less base funding that will be available to meet the needs of community health centers. I think that the reason they got rid of this extra funding is because they figured, well, by that point there's going to be a bunch of people with health insurance coverage and they can get the revenues through Medicaid and through the private coverage through the health benefit exchange. But it's going to be a real challenge in states that don't choose to expand Medicaid, because the population that Phil serves is largely the folks that would otherwise be in the Medicaid program. And if the state chooses not to expand Medicaid, then those people will remain uninsured and they'll have less federal funding to help offset the cost for caring for the uninsured.
And the big thing about this is folks have to understand no health care is free. We talk about charity care. The people that pay for charity care are the people that have insurance, and the people in the federal government that get Medicare or Medicaid, that they are the ones that pay for charity care. Now, who is the best payer of all? The self-person, the individual person who gets a bill for $10,000 and then they have no insurance company to fight for them to get that bill. The insurance company may have paid only 75 cents on a dollar. But that person is going to end up paying 100% on that dollar if it takes them the rest of their life to do it. So, you know, that's why one aspect of it is that when you look at who is the best payer for health care, the single individual person is, but putting them on an insurance policy helps to decrease the cost. And then it also decreases the other costs of where they get that care. Oftentimes it's the most expensive place, which is the emergency room, as opposed to being seen in a primary care clinic, such as Lincoln. Now, where Lincoln is different as it relates to federally qualified health centers, it sees chronic diseases. Many of our federally qualified health centers really only see women and children. as opposed to seeing people that have chronic disease. That's where the issue of the uninsured at Lincoln comes into play. When you have 87% of your people at or below 200% of the family poverty level, those people can't self-pay. They barely have enough to be able to pay the co-pay. And then on top of that, think about it, they're the working poor. So not only did they pay the co-pay, they paid because they didn't get to work that day, so they don't get paid. And then they pay again whatever prescriptions that they have. And that's where some of the things that the fairly qualified health centers have in place is the 330 grant and the drug benefit grant, where they go and they work to develop relationships with companies that have indigent care for people that meet the federally qualified, the federal poverty standards, in order to get their drugs at a reasonable price. And that to me is the model that we have to look at. And then on top of that, the relationship that Lincoln has with the major health centers in the area that contribute money to Lincoln, and the aspect of understanding that it's like the Midas commercial. You can pay me now, or you can pay me later. And the bottom line is that if they pay Lincoln now to try to keep people out of the emergency room, that costs them a lot less money than having them come to the emergency room and then referring them to Lincoln.
Thank you. We're going to switch it just a tad, talk a little bit about state decisions with regard to ACA and how there may be racial differences in the populations of people that may benefit from the decisions that may need to be made in the state. Adam, we'll let you go first on this one. What do we need to be paying attention to at the state level?
Well, I think we've already mentioned the main thing several times, which is whether or not the state expands North Carolina's Medicaid program. And that's absolutely critical. You're talking about 500,000 people in the state, just about, who would be brought into the healthcare system and able to pay their bills if the state makes the decision to expand Medicaid. And I think that will just have a huge effect on our ability to not only bring people into the system and cover them, but to start to get the data and start to attack some more of these disparities.
Can you talk a little bit about how it's funded, the expansion of Medicaid, how it's different
Sure.
from the current Medicaid?
The Medicaid expansion will be funded for the first 3 years. It's funded 100% by the federal government. And then over 6 years, then it drops down. But over the usual numbers that are being looked at now are what the cost is over the first 6 years. 93% of the cost is funded by the federal government. But it's the state's still working on exactly how much money is coming in, but it's somewhere in between 15 and 20 billion with a B dollars that will come to North Carolina, and that's paying doctors and hospitals, especially rural hospitals and health clinics and community health centers to provide care to folks who've never had coverage before. Over that same 6-year period, the estimate is, it was the preliminary estimate, about $830 million is what the state will have to put out, because there'll be more people who are coming into Medicaid anyway. We've taken a preliminary look at it at the Justice Center, and there's just so much care that's paid for by local governments, and at least some of the thinking that when we've been looking at it is we're just going to save so much money because so many people will be covered by the new mandate by the new Medicaid coverage, that it's going to be close to a wash, we think, for the state in the end. And I think the other thing you have to be clear about is this doesn't just benefit those 500,000 people who are under very low income, under about $15,000 a year in annual income. It really does benefit a lot of the healthcare providers and infrastructure and economy of the state, which is kind of we should be putting people first, but when you pump $20 billion into the state's economy, that's going to be a lot of jobs. I mean, that money doesn't just go out the door. It goes to people who are working really hard and taking care of people in the state.
Okay, we're about ready to open up for questions. Just one more question specifically about Affordable Care Act and how it's going to you know, be implemented at the federal and the state level? Are there specific things, you have a bunch of advocates in the audience here, healthcare advocates, are there specific things we need to be doing now besides voting to help make sure some of this expansion happens, and of course the expansion in Medicaid, North Carolina Medicaid? Are there elected or unelected officials that we should be talking to?
What I will tell you is that number one priority is to vote. And that second priority, well, let me back up. The first priority is to be informed. Such that when you vote, you put your vote when you really consciously are informed to put that vote. So that being stated, one of the things that I think is crucial that may definitely impact the expansion aspect is, you know, the Health Insurance Exchange Commission. Who sets up the boards, the folks that are going to develop your e-insurance online. My concern is the issue of having the fox and guard or the hen house, where you have a board full of folks from insurance companies who are setting up the exchange, setting up the options that you have for your to pick from. So I would say that one of the things that we as advocates need to be, telling our legislators at the state level is that, make sure that we have a board that is going to develop these insurance options that that have people that are regular people, regular Joes and Janes who are going to be utilizing this, and physicians who are going to be taking this coverage, and more of those types of folks rather than less of the insurance companies in place. And that would be just one thing that I would mention.
Would you describe what that board is? I don't know what that is.
So,
board.
You want to do that?
Yeah, the federal government requires every state to have a health benefits exchange. That's the Expedia.com that I was talking about, or the Amazon. It's the e-system where you can enroll online. Either the state can create its own health benefits exchange, or the federal government will create one that will cover each state. North Carolina has not yet chosen to create its own health benefit exchange. If we do create our own health benefit exchange, we have different options of how we would do that. One option is it would be a state agency. You wouldn't need a board then, because the state agency would be responsible. Another option would be either a nonprofit or a quasi-public. We can't have the legislature, because of our state constitution, create a separate nonprofit. So in North Carolina, the options are really either a state agency or a quasi-public agency. If it is a quasi-public, it has to have a governing board that could be making decisions about how the operations of the health benefit exchange. Under federal law, if you do have a governing board, you can have insurers on it. It may not be the majority of the board. The federal law prohibits it from being a majority, but it does allow for insurers to be on it under federal law. If the federal government creates our health benefit exchange, as best I know, we don't yet know how it would be governed. So we don't yet know what it will be. We do know in 2014 it will not be a state health benefit exchange, because we passed the point in which we could do it. At some point in the future, we could create a state health benefit exchange, and then we would be faced with that decision as to whether it be a state agency or a quasi-public, and who would govern it.
Any other advice for what we need to be doing now? Then we'll open it up for questions from the floor. We're going to answer questions. Dr. Dodds.
Well, that leads into the question I had, because I'm wondering what happened to who decides what's covered. And the reason I'm asking this is that the day that the Supreme Court made their decision, I was with a woman who has a child with special health care needs, and she's an advocate for other families. And she practically had a hysteria attack. She said, "Oh, it's all over. I'm moving out of the country." I said, "What are you talking about?" And she was so hysterical she couldn't explain to me. But I thought to myself, I think this must have something to do with coverage. That when you have a small number of people with a very expensive diagnosis, that becomes really costly to cover, and so people tend to say, we're not going to cover that. They have to wait till they get. So I'm wanting to know where does this cover, deciding what we're going to cover happen?
Well, from my national perspective, one of the things that we advocated to HHS was that there need to be a certain standard of minimal benefits that each of these type of insurance exchange policies should include. Preventive care, emergency room care, of course, prenatal care. One of the things that is not in there that we had actually fought for was dental care. Because one of the things that we see across the nation is that the mouth, for some reason we as physicians keep forgetting that the mouth is the portal of entry to the whole rest of the body. And that if you have periodontal disease, that puts you at risk for other diseases, including heart disease. So we thought that should be one of the benefits that should be included. So from what we knew at that time, it was from HHS, and you may have further information.
Yeah, so the federal law requires that in the small group, which means 50 or under, and it eventually will mean 100 or under, employer groups of 50 or under or 100 or under, and in a non-group market, plans have to cover 10 essential benefits: doctors, drugs, hospital, habilitative and rehabilitative services, mental health and substance abuse. This is in addition to the preventive services that all insurance plans have to cover, but this is 10 essential benefits. So that's defined in federal law. That's not an issue. The question is, what do those broad categories mean? What does it mean to cover habilitative or rehabilitative services? Does it have a certain limit to the number of visits you can get? And the federal government said to each state, okay, you can define your own essential benefit package, but it has to be one of 10 benchmark plans. And the federal government gave each state these 10 plans, which would be the 3 most commonly purchased federal employees health benefits plan, the 3 most commonly purchased small business plans, your 3 most commonly state employees health plan. In North Carolina, there's only one of them. And then I can't remember what the 10th one is, but there are 10 different plans in which a state could look at. If a state doesn't select it by September 28th of this year, then the federal government will select one for the state. We did not select one. We looked at them all. It looked like the plan that was likely to be selected for us was a reasonable plan, which is the most commonly purchased small business plan, which is a Blue Cross Blue Shield plan. It's not the cost sharing pieces of it, it is what services are covered, that's the essential benefits. It's not how much you pay for each one, it's whether they cover occupational therapy, physical therapy, mental health, substance abuse, all those things. And what they cover in Blue Cross Blue Shield's most commonly purchased small business plans seemed like reasonable coverage. Because quite frankly, and this is something that's really important for consumers to understand, there is a trade-off. And the trade-off is comprehensive coverage or cost. And the broader your coverage package is, the more it's going to cost. And therefore, you help some people who have really significant health problems by having comprehensive benefits. You hurt other people because you drive up costs so much that it makes it expensive for people to do it, and they then may choose to pay the penalty rather than buy insurance coverage. There is a maximum out-of-pocket for anybody who buys health insurance coverage in 2014, and it is the HSA, the Health Savings Accounts amount, which I think for an individual is about $6,000 a year, and for a family it's about $12,000, I think. So that means that your deductible and any cost sharing, once it exceeds that level, then the insurance company pays 100% of all the covered costs. And if you're lower income, that subsidy, that out-of-pocket limit is less. So there's a subsidy for the lower income families.
So it doesn't matter what your diagnosis is, it matters how much services you're going to be drawing from that plan.
Right. It matters what the plan is going to cover.
And so therefore it's what that plan will cover in terms of how many services.
Right, it's got nothing to do with your diagnosis.
Okay, thank you, I really appreciate that.
Good question. Got another one. Bill?
Can you help us understand what different candidates or parties have said about willingness to expand Medicaid and other key things that you've just talked about?
Are you talking about at the state level? And I'll repeat the question, at the state level
I'm
and federal
thinking more
level?
of the state level, governor and others.
Okay.
I haven't read up, I don't know for sure which
Okay.
ones have gone on record that they would do A or B.
So I'll repeat that, and then I think, so Bill's question to the group is, are there candidates, and I guess, among any of the, gubernatorial and or anybody running for House Senate in North Carolina that have taken stances on the expansion of Medicaid in North Carolina?
That's a good question. The answer is candidates for office have generally said, and this includes both the candidates for governor, that they are studying the issue and they're waiting until after the election. So now that's from an advocate's perspective, I will say that is actually a very good thing from our perspective. And the reason is that our strategy is to, we think that the amount of money, we touched a little bit on the effects of the expansion, there's just an enormous amount of money that comes to North Carolina as a result of this expansion. If we don't expand, then we're going to incur significant costs anyway. So just from a fiscal perspective, it's kind of silly not to do it. From a moral perspective and a political perspective, I think, helping people buy health insurance who are a little bit, making above $15,000 a year, giving them tax credits and then leaving everybody out at the bottom is just kind of crazy, because they would be, if we don't expand Medicaid, people who make above $15,000 would get tax credits to help them buy insurance on the exchange. People below $15,000, no tax credits, no help whatsoever. So I think if you look at it just from a purely rational perspective, whether we should expand it or not, pretty much a no-brainer. We ought to do it. And I think a lot of the providers are very on board with that, but nobody wants to jump into the ideological debate before the election. So what our strategy has been is to just say, look, North Carolina, we're great, we're a leader in doing all these healthcare things. Of course we're going to expand Medicaid. We'd be crazy not to, but we're not pressing anybody, any politicians or candidates, and saying you have to come out and take a stand on this, because we think that if we keep up this and we don't put people into a box about it, that when the time comes around next year and we have the election and when the decision is made, some people will be like, yes, other people will be, well, I really don't want to do it, but the federal government's making us do it, we just don't have a choice. But we don't want to put anybody into a box about it right now. So that would be the bottom line.
Thanks. Dr. Burton.
Well, what I would want to just kind of emphasize on is two things. One is, North Carolina is already being looked at as a model for efficiency in how we handle our Medicaid population, as we have Community Care of North Carolina, which Lincoln is a part of, Piedmont Health Center is a part of, and their ability to be able to manage care of Medicaid population and lower costs to the tune of over $100 million a year, I think is serving as a model for how we can have successful expansion and still have a workable product. Secondarily, let me just throw out two numbers for you. Health disparities in the United States. Anyone give an idea how much it costs? Health disparities, how much it costs? Health disparities in the United States cost us each year $1.24 trillion, with a T, not a B, not an M, a T. $1.2 trillion, $1.24 trillion. When you add in lost productivity, when you add in lost legacy, when you add in all the other factors that come with folks having health disparities, that's what it costs for this nation. Now, for our state, it costs us about $516 million, almost $250 million. I mean, $500 million we lose each year because of health disparities within the state. So, if expansion of Medicaid allows us to be able to get people on, that allow them to be, because you already saw the numbers of who are the folks that are left out. If we can get those folks on board and get them into getting care, get them into the preventive services, really think about it. The Affordable Care Act is a huge paradigm shift. It's a huge paradigm shift. Why? Because all medicine over since the last 40 years has been driven by what? Profit. Well, is there a profit if you cure somebody? No. Is there a profit in prevention? No. That's why there's, and that's just, I got on my soapbox. I'm sorry. But for me, that's one of the major issues that you really have to think about as this decision is coming down and why people have been opposed to. And that's you know, I'll leave it at that. I won't go.
I want to ask a follow-up question. It's related to both access to the expanded Medicaid as well as the health benefits exchanges. I work at a program, one of the SHIP, Seniors Health Insurance Information Programs. We help older adults figure out Medicare, do I want Medicare A, when do I take B, what about C, that's Medicare Advantage, that's private, you leave traditional Medicare, go to Medicare Advantage. Oh, do I need D, how do I apply, when do I do it? It changes every year, how do I make decisions? Oh, I go onto a government website, what? I put my drugs in a government website, how? So Expedia sounds great. I use Expedia. I like Expedia. Not everybody who uses Expedia has access to Expedia. Can you talk a little bit about what the government is planning to help people access the services that are supposedly there, and a little bit of the woodworker effect, not woodworkers, that's okay, woodworker effect is coming from the Medicaid things.
Okay, so the bill has a couple different provisions in it. First, it says the Medicaid agency must do outreach to specific populations that are considered vulnerable populations. Racial and ethnic minorities, homeless children, people with mental illness or substance abuse problems, pregnant women, victims of domestic violence. There's a whole list of them. And the agency has an affirmative obligation to do outreach to help them understand their options. That's on the Medicaid side. On the private side, on the health benefit exchange side, as Gina mentioned, the model that they really created was our SHIP program, which is the Senior Health Insurance Information Program, which some of you may be familiar with. It's where they train basically volunteers. You have to be certified, go through a Department of Insurance training, and then you go out and help people when they are trying to make choices about what plan is best for them. And you help them walk through what's available on the website, and then I don't think you're actually supposed to give advice, but you give them information about what the different options are that are available to them. That's the model that the bill has in there for the new plans that will be available through the Health Benefit Exchange. The Health Benefit Exchange has to contract with what is called a patient navigator. Some of you have heard of that term in a different context. It's usually used in the context of helping people understand where to go for care and how to get through the healthcare system. They're using the same term, but it's really to help them understand what their different insurance options are, how to get online and how to figure it out, and then to help them decide which is their best option. Those are called patient navigators. There's a really weird quirk in the law that says that the Health Benefit Exchange is supposed to pay for patient navigators, but they can't use federal grant funds to pay for patient navigators, and there's no other monies that the Health Benefit Exchange has for the first 2 years. After the first 2 years, they'll get monies from insurance companies or other sources. But for the first 2 years, the only money they have to operate is the federal grant funds, and they can't use the federal grant funds to pay for patient navigators. And the first 2 years is really when you need patient navigators, because that's when everybody's going to be enrolling for the first time. So what the federal government now is doing is saying, okay, we'll figure out something about patient navigators, but in the meantime, you can have informal assisters. What's an informal assister? Well, as best I can tell, they're patient navigators called a different name. They're going to be trained, they're going to be certified, and they can be paid through federal grant funds.
Yes. Is your funding going to be such that it'd be like full, or is it sort of like SHIP?
It's SHIP.
It's SHIP. So when it says paid, we're the SHIP site for Durham County. We'll get $7,100 this year, and it costs us over $200,000 to do it. So it's very much volunteer driven. But you know, all healthcare is local, so it's local people helping other people understand options. But it's not really a fully paid position. So you know, access is access. I mean, access only goes so far, right? So I think that's a big concern. Yes, question, that's you. Sorry.
Okay. So I have two questions, all with sort of health disparities in mind. The first one, similar to Jan's, in terms of Medicaid, is there the ability to, sure, we'll increase Medicaid, you know, how many people are on Medicaid, but we'll lower the amount of services eligible, you know, where the actual services that people on Medicaid get aren't what they are now? So that's my first question. Is that something that we have an option at the state level? My second question is, knowing the recent history in North Carolina around mental health reform and thinking how we got rid of public mental health and privatized it, basically you're taking government funds and putting them into the private sector, and we saw how, you know, we didn't necessarily get it right the first time. And knowing when you have this new supply and you're serving vulnerable populations, there's going to be some exploitation perhaps, or I wonder if there are any concerns that people have looked at to make sure that doesn't happen, to sort of take that supply, you know, with the demand and in a way that maybe isn't what we want it to be.
So let me answer the first question about the Medicaid services. The federal law for Medicaid right now has a number of mandatory services and they have optional services. Under the federal law, for the people who are currently covered, we have to cover the mandatory services and the states cannot eliminate that. We have never had to cover the optional services, but we have chosen to do so. Could we eliminate optional services today? Absolutely, and we have actually done a little bit of that in the last couple of legislative sessions. Could we eliminate optional services 2 years from now when the Affordable Care Act comes in? Absolutely, we could do it today, so we could do that then. That's for the people who are already eligible for Medicaid. That's what we call the existing eligibles. Whether they're on today or not, the people who could become eligible today if they went into social services to apply are called the existing eligible, and they're entitled to those mandatory and right now whatever state optional services we've chosen to cover. In 2014, there will be this new group of people who aren't currently eligible. We're calling them the newly eligibles. Those are people who, if they went down and applied today, they couldn't become eligible because they don't meet the requirements. But they will be eligible in 2014, assuming the state chose to expand Medicaid. For that group of people, the state has to choose a benchmark plan that can be different than what they cover for the regular Medicaid population. But it can be no less extensive than that package that I just told Jan about, that's 10 essential benefits. So for the newly eligible Medicaid, they're going to be somewhere between what's available in the health benefits exchange and what's available for traditional Medicaid, and it could be anywhere in that spectrum. And we don't yet know what we're going to choose. That's an option the state is still trying to decide.
And actually, if I could just ask you a question on that, since I'm getting a little bit of information myself. Presently, the already enrolled Medicaid people, are they actually getting a package? The things that they're getting plus the optional packages, are the 10 essential benefits in that package already?
That's a great question, and actually there's a couple of areas where the 10 essential benefits are better than the Medicaid expansion. As a general rule of thumb, the Medicaid coverage is always better than private coverage in terms of what it covers. I will tell you that there is no other private plan that on paper covers as much as Medicaid does. But there are a couple of areas where the essential benefits package is more comprehensive. One is what's called habilitative services. Habilitative services, there's two things in the essential benefits. One is rehabilitative services. If you have a stroke, you've lost your ability to speak, you go out and you then need to get speech therapy to regain your ability to speak. That's called rehabilitative services. If you have a child born with special needs who never knew how to speak and needs long-term speech therapy just to get some ongoing ability to speak, that's habilitative services. Those services are not traditionally covered in Medicaid, but they're supposed to be covered under the essential benefits package. We don't know what that is. The other really weird, there's a number of weird quirks in the law. Just to put it in perspective, there's always weird quirks in the law. So this is not unique, and that's why bills get changed over time. But another really weird quirk in the law is that the federal law says for the commercial population, we are going to get we're going to all get coverage for all clinical preventive services with no cost sharing. Anything that the U.S. Preventive Services Task Force recommends with an A or B recommendation, any immunization recommended by the Advisory Committee for Immunization Practices, all of us will eventually get that as part of our regular insurance coverage, and we won't have to pay deductibles, cost sharing, co-payments for it. That's for the commercially insured population. For Medicaid, that's an option. Medicaid does not have to provide coverage of all clinical preventive services with no cost sharing. So for the Medicaid program, they could choose to have cost sharing. They could choose not to cover all preventive services. There's a financial incentive for states to do the same thing for Medicaid that they're doing in the commercial, but they don't have to.
Let me just, on page 299, stroke C is the, I would say, I learned so much from Pam when we're over here. I didn't realize that about the Medicaid. I'll tell you, as an advocate, I'm not worried about, at this point, that much about the benefit packages and the essential health benefits package, the Medicaid benefits package. I'm not worried about that. I'm worried about, are we going to expand Medicaid, and are we going to have a decent health exchange where it's easy for people to find plans that work? And I think we can get there, but those are the two things as an advocate. I'm not as worried about that.
And if I just may quickly just add this 2 points. You talked about, same amount of money, increasing the number of people, you have to decrease the amount of services. That's why on a national level we have fought against block grants for the longest time with our Medicaid population, because if you have only a certain amount of money that you're going to only get in a year, and you have an economic downturn, and then unemployment increases, well, we're supposed to enroll those people onto Medicaid. And that's how we know that Medicaid is actually working, when it takes in those people that get kicked off of having private insurance. That's how it's supposed to work. If you have a block grant, you can't increase those number of people. They have to wait till the next funding cycle to apply. Secondarily, I think this is a very crucial point that you brought up about the United States Preventive Health Task Force. It's very salient for me, because I'm an African-American male. And one of the things that they came out with was they don't want to they say that doing PSA testing in African-American males, in males period, to look for prostate cancer is not warranted. And they said we should stop doing it as clinicians. Well, if an African-American male, I have almost a 200% more likely to develop prostate cancer in my lifetime. In fact, oftentimes, prostate cancer in African-American men that die in the age 50s started at the age 40s. So, for me, and if it gets to the point where they start to do that and say that we're not going to reimburse you for doing that test on that patient population because the task force said that, what we're going to find is that you're going to have an increase in disparities because you're going to see more deaths. It's the same thing with breast cancer and the use of mammography between that age group of 40 to 49. They said it was mercury. But after enough public outcry to say that those are lives that we're playing with, and I understand the whole aspect of evidence-based medicine. And we talked about this earlier. Evidence-based medicine is great when you have a base of people that you get the evidence that is representative of the population of the evidence you're trying to apply to. But if you're doing evidence-based medicine on prostate cancer, looking at populations that have a 1% prostate cancer prevalence, as opposed to having a study that has patient population representative of those that have a 15 to 20% prevalence, then okay, then maybe you have some weight behind your decision. And that's one of the key things that I think. We cannot get to health equity. The goal is to get to health equity. But the goal to understand health equity, it can be one or two things. It can either be the race to the bottom, Everybody's equal and it all sucks. Or it can be what we really want in America, which is what we always had in America, is that we have a race to the top and everybody gets the best.
Yes, question.
I'd like to tie into what this gentleman asked about any law that we make, unless you have enforcement, it goes down the tubes. And if all of us don't understand that after what happened in 2008, well, you know, it's a shame. So what is going to be done? Where's the money to make sure that these things are going to happen?
Great enforcement question.
And I have another follow-up also I'd like to ask.
Okay.
Enforcement of basically all of it, or, I mean, and that's...
All of it, or have individual mandate?
Well, we're hearing that insurance companies can only now spend 20% on overhead costs. Who's going to regulate that? Who's going to go into their books? Who's going to make sure that they're doing the things that we're saying they should do? What about the fraud? We know there's $750 billion a year of unwarranted medical costs in this country. That's one of the things I want to know about.
I mean, first of all, like your first question, for instance, who's going to make sure the insurance companies give the rebates they're supposed to? Our insurance commissioner is in charge of enforcing that. They have regulatory authority over the insurance companies. They can make them open their books, and they did it. And we got fewer checks in North Carolina because the biggest insurer in North Carolina, Blue Cross Blue Shield, was actually within the guidelines for spending, under 15% of their premium dollars on administration. So, but people got rebate checks, and that's because the insurance commissioner enforced it. So, there's a whole. I don't have as an advocate, I don't have a worry that the enforcement of parts of the law like that is that there's a worry. I do not have the worry that it's not going to be enforced, because the parts of the law that are already in effect, they are working and they are being enforced. I mean, either there's been voluntary compliance, or like the insurance commissioner did in our state and in every other state, has gone in and made sure those rebate checks happen. So, for instance, the part of the law that says insurance companies have to allow children up to age 26 to be on their parents' policies. Every insurer in the country is complying with that policy. So I don't think anybody's, at least from my perspective, I'm not worried that that's not going to happen. What was the other part of your...
Fraud.
Oh, fraud. Yeah, fraud. I mean, you can maybe talk to us more because you've been in the middle of it, but there's been a huge increase. I explain myself. Just because you're in the middle of the debate, and I've been I think there's been more collected by the federal government in enforcing some of these fraud provisions in the last couple of years than in the last 10 years. So they have new expanded powers, right? There's huge expanded powers to do this, and they keep, it seems like there's a press release, and it's politically, it's nice, but there's a press release every other week from the Fed saying, oh yeah, we collected X amount more, cracking down on fraud in the Medicaid program. So.
And I will say that in the very first year after the legislation was enacted at the federal level, they required states to put in new provisions to protect against fraud in both the Medicaid and our children's health insurance program. It was legislation that was passed in the North Carolina General Assembly. I know some provider groups are really concerned that inadvertent errors on their part will then be considered fraud, and if they are kicked out of one program, they'll be kicked out of all programs. So I know at least on the provider side, there's some concern that we may have gone way too far on the other side in terms of trying to enforce against fraud. But there is much greater emphasis and oversight on fraud now than there has been in the past.
We've got to wrap it up. So I think 2 more questions, then we've got to wrap it up. Thanks.
Okay,
I just wanted to take us back to the healthcare exchange. Many of us, and I'll just say openly, single-payer Medicare for all advocates, had hoped, along with Senator Bernie Sanders, that the healthcare exchange would be like the public option that we didn't get, and would take us out of the domination of healthcare by the insurance companies. But you mentioned, as some of you mentioned, the restrictions of North Carolina in particular. We don't even know if they're going to accept the exchange. If they don't, what happens if the feds take it over? But if they do, what is our role as voters and advocates and citizens in getting that health care exchange to provide the kind of services, comprehensive care and cost that would not otherwise be available or shouldn't be available in the insurance industry? Could it be a counter to the insurance industry, given the restrictions you said?
The legislation that was created under the Affordable Care Act builds on our private insurance market. There is no public option allowed. There is a nonprofit co-op option allowed, and I have started for the first time recently hearing that there are some people in North Carolina who are considering putting together a nonprofit co-op to be offered in the exchange along with the private insurance plans. It is very complicated to do that. I don't know whether it will get off the ground or not. There are federal loans available to create nonprofit co-ops, but I've just heard about it for the first time. Actually, this last week, somebody told me that there's some discussion now going on about that. So I don't know if that will happen or not. And that will be irrespective of whether we do it at the state level or the federal level, because that's really not an exchange. It doesn't matter whether it's a federal exchange or a state exchange. If you can meet the requirements, then you can be offered in whatever it is.
Yes, that's you.
Okay. Just wanted to hear your perspective real quick. You mentioned a little bit the sort of shortage of primary care physicians. And coverage is nice, but if you don't have doctors, what happens? So real quick, I was wondering if you could elucidate what's the current status of primary care physicians in North Carolina? And then also, I guess, for each of you, in your wildest dreams, I understand there's like loan forgiveness options out there, but in your wildest dreams, if we were to push for reform in the near future, what would a sort of program that would encourage primary care physicians to sort of, what would that be?
So there are sufficient primary care providers in the state to meet the current need. There aren't sufficient primary care providers in every county. So if you take a look at the state provider to population ratio, we're about at the national average. If you take a look at specific counties, we've got shortages. And I can't remember, maybe 20 or 30 counties where there are health professional, primary care health professional shortage areas. I just don't, I'm making that up. There's some number, and I just can't remember it offhand.
It's about 20 counties.
Right. So there has been some expansion of health professionals, the National Health Service Corps, which would get people into underserved areas. Of course, that means that you have to have more people trained. And there isn't a huge amount of new money putting into training doctors. On the other hand, there has been new money put into training PAs and nurse practitioners who also can provide primary care. As Cedric talked about earlier, there has been a much greater emphasis on team-based care where you can get nurse practitioners, PAs, psychiatrists, licensed clinical social workers, pharmacists, all working together as a team with the goal of expanding services to the population. And I think in the short term that hopefully offers some promise, which is what was talked about earlier. And I know in North Carolina we have done better in terms of getting some monies for nurse practitioners and PAs. We've gotten a little bit of money for primary care residencies. And the other big thing that's happened that is outside the Affordable Care Act is that Campbell University is opening up an osteopathic medical school, which will also expand access to physicians.
Being that I'm a dean of admissions, you know, one of the things that we have heard the issue, if we look at our population of physicians here in the state, only about 35% of our physicians within the state actually are made in this state, meaning that we are a net importer of physicians. What we see is that of the net physicians that we import, almost 36% of those are foreign medical graduates who are coming in and taking positions in our state doing primary care. Primary care is pediatrics, OB, primary care medicine, family medicine, general surgery. That's what we call the 5 areas, and that's data from the Shep Center that I'm quoting there. One of the ways that we're going to meet the need, technology. We're using Skype and interactive ways to do telemedicine. They already have developed apps that allow people to put a phone on somebody and I can hear his breathing, halfway across the country. This is stuff that we've developed through our military as we've gone about doing fighting in these wars in the Middle East. These are, I think, some of the answers that for specifically what you're asking. It's not going to be a boom. We can't, like I said earlier, put in some water, poof, instant doctor, ain't going to happen. So we're going to have to be creative in how we do this, and I think, and another aspect of it is the lay health professionals. I've seen some interesting stuff coming out of Stanford where they have developed these lay health professionals that actually can go out and help people with chronic diseases in the community be more adherent to their medications, and end up with better outcomes because of the fact that they're getting one-on-one didactics. We had a program very similar to that here. It was called Promising Practices. Am I not, Gayle, am I get that name right?
That's right. It's gone now, but
yeah, it's gone. It's been gone a while. But see, the unfortunate thing about medicine, and this will be my last statement, is that in so many ways we have had so many innovations that have come up as studies, right? That really benefit communities and really impact people's lives and really make them better patients. But the problem is we've never been able to develop sustainability, because these programs save money, which is a soft thing. They don't generate revenue. Oftentimes when we save money, we don't reimburse that money that we save into a program that helps us save more money. It goes into a product line that is help to generate more revenue. That's my last thought.
just last question, and then we've got one final question for everybody.
Okay, this deals with what individuals will pay for their insurance. I'm a small business owner. We have a group policy. In the last 5 years, our company's policies, even though we have searched high and low across the various companies, and Cigna, WellPath, all these Blue Cross, they're going up 12 to 18% a year.
That's right.
Now, I see that as their profit. They see this mandated coverage, so they get the rates jacked up. My employees cannot afford to go to the hospital, even though they have health insurance. They can't take the day off. They can't go pay copays and deductibles. And then when our plan has a $2,000 deductible, they've got to pay that out of pocket. Then it's 80-20 coverage on top of that. So if they have any kind of a major problem, they're going to the doctor constantly. I'd love to be able to pay them sick leave every time they had to get off and pay for all the insurance, but I can't afford to do it. So my question is, are we really going to help the working people by having policies for them? I hope we are. But what I'm seeing as a small business owner with people who do blue-collar work is that they're screwed now, and it looks to me like they're going to continue to be. So please give me some assurance.
Affordability question, you talked about balancing affordability with access. I would just ditto what you just said. I work with a small nonprofit. We have the exact same health insurance you do. $2,000 high deductible plan, but preventive services at least are covered now, right? But then it's 80-20 after that.
So will the health exchanges?
Well, so the question is are the prices on the health exchanges going to be better than what we can get on the market now, some degree?
Yeah.
And we don't know the answer to that. Until the plans are developed, we don't know the answer to it. I mean, on some levels, it could, for some, I think the easiest thing to say is for some people it will be less expensive and for some people it will be more expensive. Even irrespective of the subsidy issue. Because if you, right now, within certain allowable limits, they rate your plan based on the health status of the people in your plan. If you have a very healthy plan, you have a lower rate than if you have a very sick group of people in your plan, That, you can't do that anymore beginning 2014. In group plans right now, you can't do it a whole lot, but you can do it a little bit. They'll look at the health status, they'll look at use of services and rate it up or down, I think 25% in small group plans. That goes away in 2014, they can't do that anymore. So those groups that were healthy will pay a little bit more. Those groups that were sick will pay a little bit less on average, assuming that the benefit package were the same. The benefit package might change a little bit under the new essential benefit package. That's why it's hard to say whether the overall cost is going to go up or going to go down, because it really depends on each individual. However, if you are buying health insurance coverage on your own and your income is between 100 and 400% of the federal poverty guidelines and you don't have access to affordable employer-based coverage, then you're eligible for subsidies, and for many of those people who are eligible for subsidies, it will make it cheaper for them to buy coverage.
I'm just looking at the federal poverty guidelines. So a single person at 100% of the federal poverty guidelines, below which is going to be eligible for Medicaid, would be about $11,000 now. If I made $11,000 a year less, I'm at 100% of the federal poverty guidelines. I would get subsidies if I made up to $44,000 now. Just roughly $44,000, $45,000. I could get some help. If I was in your plan, I said, I could afford, if you were making your employees pay it, if you were making your employees pay it, and they said they couldn't afford it, they could go on the exchange and buy if their income's below $44,000.
And if the cost, the premium exceeded 9.5% of their income.
And if the premium exceeded 9.5% of their income. Now then I have a question of your earlier question. Who's going to enforce all of this? So that's a great question. I think there's one more question, and then we really are. I've got a final question for him. Hit it.
Sorry, this kind of follows up on his question, but it kind of changes the conversation from this insurance-driven explanation of what the Affordable Care Act is doing to kind of talking more about the cost of what the actual care is. And so, how is, if any, the Affordable Care Act impacting the cost of these services that are being provided, which in turn will influence how much the insurance policies are themselves?
There's a couple things that the Affordable Care Act tries to do, and I think that that's a really good issue. The one thing that they do, which I didn't talk about in my presentation much, is there's a much greater emphasis on prevention than we've ever had before, both on primary prevention and on secondary prevention. So what do I mean by that? Primary prevention is helping create the conditions so that people will exercise, that they'll eat healthy, they won't smoke. Those are the things that keep us healthy to begin with, or not sick. Secondary prevention is once you get a chronic illness, how do we make sure that people understand how to manage their chronic illness so they don't end up in the hospital with uncontrolled diabetes or asthma or whatever that drives up costs and makes, it just contributes to our cost escalation. One of the things that everybody should know, this is the thing I teach in the School of Public Health, I think is the most important fact that we should know about our healthcare system, is that 10% of the people in our country use 64% of all healthcare dollars. We have some people who are really, really sick, and they use a lot of dollars, and we need to help try to figure out how to manage that group of patients. And that's a lot of those folks with uncontrolled chronic illness. So that's the first part of it. The second part of it is there's a lot in the bill to test new ways of paying for and delivering healthcare services, to try to incentivize the doctors to work better, the community doctors to work better with the specialists, to work better with the hospital, so that when somebody leaves the hospital, they don't end up with a readmission 30 days later, because there's a warm handoff and people know what they're supposed to be doing in the community to manage their care. There's a lot more emphasis on improving quality of care so we understand the quality that's being provided and we incentivize providing better quality care. The frustration is we don't know how to do it yet, so everybody's really upset because the bill didn't do more to say net on 2014 healthcare costs are going to go down. It doesn't do that because we don't know. We know what works in Mayo. We know what works in Geisinger, but what works in Mayo and Geisinger may not work in Bertie, North Carolina, that hasn't had a history of an integrated delivery system. So we have to figure out what works in Bertie and what works in Orange County and what works in Buncombe County. And when we figure that out, what that legislation does is then allow the Secretary to expand that across the country.
One area that we hope to get significant cost savings is in the decreasing of duplication of services. And that's where the whole HIT movement with the, health information technology, I have to always remind myself not to use the acronym so much. and then the HIE, which is the Health Information Exchanges. And where that is so crucial is that there are two ways that we can do it. We can either give everybody their own electronic medical record that they walk around with, and they take the USB key, and every time they go to a doctor, poof, you put it in the computer, up pops all your information, right? That's one way to do it. But the worry with that is how USB keys become corrupted, and you put it into somebody else's system. It might not read it, or it may deliver a virus. Okay, got it. Good. The second aspect of it is then you must have developed systems of information that can flow from the physician's office to the hospital to the community health center to every place. That everybody has a electronic medical record, and all these electronic medical records have the ability to speak to each other and to be able to share information, whether it's in a cloud or it's here on the ground. And the whole idea behind that is if by doing that, we hopefully will be able to decrease duplication of services and repeating a test. Because I mean, if I've seen that one time, I've seen it 1,000 times. A person comes in, they got a whole folder of all their medical records from another place, and they just got blood work last week, and they go, "Oh, that's great. Well, let's see, what am I going to order? Let me order some blood work." Yeah, when the person just brought it in, why do I need to reorder that again? And that's one of our major areas of I think, excess costs within our healthcare system.
Thank you. One last question for everybody the committee came up with, and this is more of a personal question. What propels your passion in your work to improve health of North Carolinians? I told you these questions ahead of time. They didn't read their emails. That will teach them.
I'm actually not afraid to answer that question. And answer that question is because I became a health disparity. My father is a health disparity. He died from lung cancer as an African-American male. You saw the data. My wife and I, we lost 3 kids trying to have one. Didn't ever think about infant mortality until that happened to us. We had a stillborn. And that was, that's when it hit me square between the eyes. My wife just recently developed breast cancer. And that's another one of those things where all of a sudden you just start realizing if you live long enough, sometimes just things happen to you in life. And, for me, it's not so much that I feel down about these things. In fact, each one of those was a blessing to me because it helped me to understand how other people have lived and how other people have overcome. And therefore, for me, I can't get down. I can't wallow. What I have to do is I have to pick up my advocacy stick and I have to go out and fight for people each and every day. And that's what I do. So that's why I do what I do, because I am a living health disparity.
No practice for the frog talk.
Yeah. We've known each other a long time. We've probably talked about this over the years, but my story is it's tough to follow, Cedric, but back in the 1980s, which was a while ago, and I was in college, my aunt, one of 4 daughters on my mom's side, was one of the first women to die from HIV/AIDS, and so she was in, I guess about the mid-1980s, and my mother's family was from a very small town in North Dakota called Devil's Lake, and my grandparents are fairly conservative, but this was obviously hugely devastating to our family. But what my grandmother did after that, she had a background of being a newspaper reporter, but she spent You know, a lot of the rest of her life, which is long, speaking to, and especially during all the wars about HIV and AIDS in the 1980s until we finally, you know, haven't figured everything out, but speaking to different groups and going to churches and community meetings and you know, helping be a health advocate for people, and that was very inspiring to me, and so that, I think, pushed me into doing what I eventually did.
Oh my God, did I make a mistake by going last? Okay, that's the end. There's no way I can talk to her.
Okay, and we know she's a health advocate, so. And many of you are health advocates. You know, the one-on-one conversations that you have with neighbor and friends about the Affordable Care Act, about why you care about health disparities, why we need to create change in this world. I look at Gayle Harris. I know in the work that I do, and certainly in working with some of the folks that are on this panel and other people in the room, it helps to have knowledge. Knowledge is power, right? It also helps to have people working with you so you don't feel alone. And so I just tip my hat to all the people at the table for the fascinating and wonderful work they do to improve the lives of people in North Carolina and beyond, mind you. And we'll work on your frog situation down there on this mountain. Thank you all.